we would like to present an acute case of myasthenic crisis. Myasthenia gravis is a rare disease that can easily be missed. The presenting symptoms usually include ocular myasthenia, ptosis, diplopia, dysphagia, dyspnea, dysarthria, and weakness. The incidence is greatest in female young adults and in older men. The disease severity is greatest in the first 5 years of symptom onset for all but about 15% of patients, with an incidence ranging from less than 1 to 24 cases per million persons. It is certainly a rare disease, far less common than a symptomatic counterpart being cerebrovascular accidents, which occur approximately every 40 seconds in the United States. Classic symptoms are fatigue that is worse at the end of the day, and fatigue that is increased with repetitive movement. Diagnosis is made clinically using the hydrophonium test, the Tensilon test, assessing seropositivity with the respective acetylcholine receptor autoantibodies, and of course the ICE-PACK test, all of which are unlikely to be tested if not on the provider's differential. We will also like to highlight jaw stiffness present in this patient as a highly specific sign of myasthenia gravis to differentiate it from other neuromuscular diseases. The clinical case we present here is that of a 77-year-old male with a past medical history of myasthenia gravis, hypertension, hyperlipidemia, GERD, and hyperthyroidism. He had a 3-month history of jaw stiffness, dysphagia, dysarthria, right-sided ptosis, and right-sided facial droop, without any preceding infection, stressor, or trauma. He was formally diagnosed with myasthenia gravis by a neurologist after confirmed seropositivity with anti-acetylcholine and anti-MuSK antibodies. He was prescribed a regimen of pyridostigmine, prednisone, all of which he had been taking, but despite his regimen, he continued to have a 10-pound unintentional weight loss due to his ongoing dysphagia. Prior to admission, he underwent an outpatient CT scan of the chest with IV contrast. After the CT, he began endorsing worsening dysphagia, such that he couldn't tolerate PO medications, which consequently warranted his admission to the hospital. At the time of admission, cerebrovascular accident was certainly high on the differential diagnosis, but it was ruled out with imaging. On the 3rd day of hospitalization, however, he had sudden acute neck weakness with accompanying head droop and difficulty clearing his secretions, with worsening ptosis and hypoxia. He was initially placed on a non-rebreather and transferred to the ICU. Subsequently, he was intubated. He had incomplete benefit from IVIG, completing 4 doses, and steroids in addition to his pyridostigmine. Therefore, under the guidance of nephrology and neurology, he received 5 rounds of plasmapheresis alternating every other day. His symptoms dramatically improved. There appeared to be no dysphagia, no dysarthria, no ptosis, and no difficulty breathing. He was formally diagnosed with acute myasthenic crisis. Azathioprine was added to his home medication regimen upon discharge because of this acute crisis episode. The patient was deemed clinically stable for discharge and advised for close follow-up with his neurologist. Myasthenia gravis has been increasing in prevalence for many decades. Owing to its growing prevalence as well as symptoms reaching maximum severity by years 1 or 2, it is important for providers to always include it on their differential, and especially in patients who are presenting with neuromuscular junction-like diseases not explained by cerebrovascular accidents. We recommend a high index of suspicion for patients undergoing multiple workups for chronically developing weakness, such as in this case of this patient, with a 3-month history of dysphagia, dysarthria, ptosis, facial droop, and jaw stiffness. Thank you.